So as you can see from our title, we're going to talk about the psychological side of diabetes. And we're going to do that by hopefully dispelling some myths about psychology, maybe even psychologists, and then also really kind of emphasize some of the main points of what we do, which is we're really interested in optimizing and improving quality of life and health outcomes in your kids. So the first place I was going to start was to ask you guys, as a myth or fact, I think that this is actually the... I'm not really sure what's happening. Hold on one second. Okay, there it is. I think that they had the opposite slides. So this is the first question I want to ask. If your child sees a psychologist, he or she will be determined to be crazy. What do you think? Myth? No, it's actually entirely true. No, I'm just kidding. And one of the things that Michael and I were just talking about before we came up was we probably should have included a slide about the fact that we don't collect stool samples. But one of the interesting things, and we put this up, it was a little bit of a joke, but you know, the reality is that there's a lot more craziness in the people caring for your kids than your kids yourself, okay? And this is just to kind of lighten it, but also to note that when we see anybody, whether it's a new diagnosis or somebody coming in for some any kind of difficulty, our first thought is not to figure out if they're crazy. Our first thought is, what can we do to help this family? What can we do to help this kid? So what about this one? Major diabetes organizations pay attention to the psychological side of diabetes. Myth? Fact? What do you think? How many think that's true? Myth? So mixed response, and I think that probably echoes what some of your experiences have been around interacting with different organizations. So the reality is that in a recent publication from the American Diabetes Association in the journal Diabetes Care, where they talked about different guidelines, and also what's reflected in a joint collaboration between the ADA and JDRF called the Type 1 Diabetes Sourcebook, they highlight a couple things. First, that the assessment and appropriate management of psychosocial issues are important throughout the lifespan of individuals with type 1 diabetes. So if this is something that you don't have access to, this is something you can advocate for. It's in the guidelines. It should be standard of care. They also talk about some specific things like screening for depression and distress, and that those should be built into routine clinic visits for your kids. And some of the reasons why this happens include the fact that there are a number of studies that talk about how important it is to be an effective coper and problem solving around diabetes. And this holds true for kids, young adults, adults with type 1, and their parents. So in this study that was conducted at Yale and published in the Annals of Behavioral Medicine a few years ago, they looked at 327 youth with type 1 diabetes and their parents. And they asked them a whole host of questions about coping with and acceptance of type 1 diabetes. And there are a number of other studies as well, this one by Dr. Harris and colleagues. And what you're going to see across these studies are similar themes, whether it's from 15 years ago or 2 years ago. And those themes are... one of the things that they found was the use of coping strategies such as acceptance, as well as engagement coping strategies such as problem solving, were linked with better self-management and better adaptation. And I don't think this would be surprising to anybody, but the reality is that there's a large evidence base about the fact that when we cope, accept, and problem solve better with diabetes, we do better. And also, that when you think about some of the difficulties with taking care of diabetes, whether it's checking blood sugars, boluses, whatever it might be, that poor adherence to treatment or poor self-care or family management of diabetes was associated with ventilation or kind of just getting it out and complaining or avoidance of it. Those are the things that tend to cause problems versus the more active copers and problem solvers.
Okay, so myth or fact? As a parent, you have less influence over your child's behavior than his or her peers do. Depends on the age? You think it depends on the age. Actually, it's either a myth or a fact, and it has nothing to do with age.
Myth.
Some say fact, some say myth. All right. So the fact is that the most influential people in our children's lives are parents. And they're watching you, they're listening to you, and they're modeling your behavior, for better or for worse. And some people would say, well, during adolescence, peers are actually more important. Peers are more important in the sense of engagement in social activities and wanting to be around them. But the fact is that even during adolescence, parents are still the most influential people in the child's life. And so we say things like, do as I say, not as I do. Modeling, we've seen this in the research, it's pretty clear, modeling as a parent is probably one of the most effective strategies that you can employ to shape your child's behavior. Whether they're biologically related or adopted, it doesn't matter. They live 24/7 with you, and they're watching you and they're listening to you. And so if you want to, while many of you may not have diabetes, and so you're wondering, well, how do I model to my child taking care of diabetes? What you can model is taking care of your own health. What you can model is how you approach health care and whether you get regular visits and what your preventative health regimens are like. Do you smoke? Are you overweight? Do you eat too many cheeseburgers, right? So those are the things that set in motion. And do you exercise? Those are the things that we know set in motion how our kids will then function and cope with the challenges of their health. I get a lot of pushback from parents sometimes when I'm working with a young person, and I'll say just that. You know what? I think one of the ends here for your child is for you to start changing your health behaviors. And they'll say, I don't have diabetes, right? Or this isn't about me. And that's for me, very sad, because as a parent of a child with diabetes, that's the least you can do to support your child is to take a look at your own health behaviors and manage them differently. So it's been established in the research across the board, exercise, the consumption of fat, the consumption of fruits and vegetables, you name it, smoking. Do you know what the rate of the rate of smokers, of kids who have parents who smoke? It's upwards of about 70%. It's incredibly predictive of whether a child will smoke. The other variable that's actually the most predictive is education. So as education increases, smoking decreases linearly. But smoking, interestingly, in terms of health behaviors, is one of the most stable health behaviors we've seen. It hovers around 25% still, and has for probably 30 or 40 years. So this is what we found is the probability of an adolescent having a low-fat intake was 5 times higher if the parent had a low-fat intake, okay? And with the exception of frequency of mothers, frequency of exercising, there was a positive correlation between parents and their children for all other health behaviors, okay? So once again, there's some things that we can't change in our children in terms of their temperament and how they're wired, but this is something that we can actually shape and influence in our children. Is this me or you?
This is you.
It's me again. Oh, okay. So myth or fact, your child should be taking care of diabetes on his or her own by 15. Myth? Any facts in there? No, all myths. Some facts? One fact? Okay. So Tim Wysocki is a colleague of Korey and mine. He's at Nemours Children's Clinic in Jacksonville, Florida, has looked at the perception of physicians and parents around when a child should start mastering the different diabetes management tasks. And who do you think expects children to master those tasks earlier? Parents, exactly. And I can understand that. My children don't have diabetes, but as a parent, if I had a child with diabetes, I would be very anxious about wanting them to get on board and be able to manage these things independently as soon as possible. However, there's no gold standard here in terms of when they start mastering this. So that people are all over the map about when a child can start regulating their own insulin, when a child would be ready for a pump. I think one of the things that we know about implementing diabetes management in children is you think about development. So when we think about development as psychologists, we think of a rose in water. And the water is everything we do as adults to nurture the rose. But each petal is a developmental sphere. So you have cognitive development, you have physical development, emotional development, moral development. And guess what? Those things don't open evenly. And you can't force them open. So oftentimes what we see is a child who's cognitively quite bright and well ahead of their curve. But diabetes is not just an intellectual exercise. So their social and psychological development may not be at the same place. In fact, that may be way lower. And so they have to manage these behaviors in a social world. And it creates kind of an expectation in children that because they get it, they should be able to do it. And we know for a fact that that's not necessarily true. So what we know based on studies is you should always stay involved, that the gold standard for managing diabetes isn't do it by yourself at some point, right? No matter how old you are, no matter how smart you are, we're asking way too much of you. And so the idea is, how do you keep people involved in helping you to manage your diabetes? So the concept of interdependence, not independence. Nobody is independent. In fact, as I've gotten older, I feel more dependent on people than I've ever been. And so we set kids up when we think independence is the goal. It's not the goal. It's how do you leverage your social support network to help you manage your life? That's the goal. And so that's more interdependence. So we want to adapt your involvement over time. So you go from having a great deal of control and oversight to maybe a little less, but you never pull out. You stay involved in different ways rather than just, we had this conversation last night at the family dinner that we as parents like to talk to our kids. And our kids hate to have to be talked to by parents. And they quickly check out. I said this last night is, what kids hear is what Charlie Brown's teacher says. Yeah, wah, 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 wah. And they have this incredible ability to make the wah-wahs go away. So I'll ask my child to do something, and they'll say, yes, Dad. In a minute, Dad. Yeah, I did that, Dad. And they never heard what I said. But they know I'll shut up if they say, yeah, I'll take care of it, or I did it. So instead of talking to your kids, behave in ways that support them, right? Behave in ways that support them taking care of their diabetes. And don't transfer responsibility until they're ultimately ready. And one thing you need to remember about kids is that at one moment in time, they may be developmentally ready, and then they may not be like a month later. And so you don't want to reinforce taking responsibility for their diabetes, because it's really hard for a child, once they've been reinforced by their parents or their caregivers to do something, when they're not ready to do it the next time, to not do it. So there's no big celebration by taking on diabetes management. It's just, do you want to do it? I'll do it. It doesn't matter. No affect, no positive or negative valence attached to responsibility around diabetes management.
Okay, what about this? Your child needs to be on a pump and use the latest diabetes devices. I kind of set it up with the underlining of needs. So I want to spend a few minutes talking about this idea, because I think that when you are, even in this room, and you may meet new people and interact with others, and there's sometimes a little bit of competition that comes up within diabetes, like, I'm doing it this way, why aren't you doing it that way? And it can be a little bit challenging for for everybody to feel like what they're doing in terms of a regimen and what their preference is going to be acceptable. So I want to talk a little bit about that, as well as some of the data on what are, from a kind of a psychological side, what are some of the data on using some of these things. So there's a large study called the Search for Diabetes in Youth study, and I've been part of some of the work that's gone on there. And one of the things that we looked at and published on a few years ago in the Journal of Pediatrics was just kind of the overall quality of life. And so this is a construct that really gets at kind of the academic, emotional, social, this is the interpersonal side of someone's experience kind of in life, so quality of life. And what we found was that a large proportion of youth with type 1 diabetes rated their quality of life at the same level as their peers without diabetes, which is reassuring. And hundreds of thousands of patients have done these kind of different surveys, not just in this study, across a number of studies, and you find very similar findings. And I think it reflects a lot of resilience on the part of both the individuals and families. But one of the interesting things when you start to dive down into it a little bit more was that we found that quality of life was a little bit lower, was not as good in the people using injections versus pumps. Now, this is a kind of a very kind of rough, kind of artificial separation between injections and pumps. But the idea was that, and kind of qualitatively, what people report is that they feel a little bit more flexibility around using that. Now, so this is a slight increase. There are some data that suggest you're going to get a little bit of a quality of life bump by using some of these technologies. But it's not massive, like I think we're made to think. Another aspect of the search study was to look at if you take these different regimens and how many people are meeting the different targets set by the American Diabetes Association or other groups. So can you actually achieve as good a glycemic control with a pump versus injections versus different kind of regimens? And one of the interesting things that they found, and if you look up here, so these are the different types of regimens. So you have pumps, you have the kind of the long-acting basal bolus in kind of this single-acting way. And then you have a couple of different types here that are a little bit more of combination. But if you look, the reality is that it is a little bit better on the pump side, but there's not that much of a difference across these different regimens. So the reality is that you can still achieve very good outcomes and not use some of these different devices. When you think about some of the new advances, and you're going to hear a lot about the artificial pancreas later on from Dr. Kowalski, and you'll hear more about it likely as the day goes along. But the ability to start this idea of closing the loop and to use different technologies, insulin delivery device like a pump, and a continuous glucose monitoring device, and have them be able to talk to each other is a very exciting area because it may make it so that we can actually check out of diabetes management for a little while. And I have type 1 myself. I'm on CGM, I'm on pumps. I have multiple pieces attached to me at all times, like many of you probably feel as well. And this is an exciting area that I'm very hopeful about. And some of you'll hear more about this later, but essentially, in many of these systems, there's some kind of device that is integrating the information from each, making decisions about what's coming up next. And what I think the benefit of many of these different systems is taking a day like this, and this is one of my days, where I'm not sure I could tell you why it was up and why it was down. And I think that this last moment when it's going 184 and shooting straight up, I think I was sitting still. So I have no idea. It's taking that and then hopefully turning it into an experience that someone could have like this, where you can achieve that overnight, you can achieve it during the day. The idea is that a system can be responsive to this. And you're going to hear a lot more about that later. But some of the interesting things from a potential quality of life benefit for both kids, adults, and parents are the reality about preventing or reducing hypoglycemia. This is a study with published by Dr. Buckingham at Stanford, a team that I work with. And one of the things that they noted in this study was that using their algorithms as part of a closed loop system to shut the insulin pump off when there was going to be a prediction of hypoglycemia, that they were able to prevent that on 84% of the time. They were able to prevent that hypoglycemia from happening. So these systems are being built. There's great technology to put us in a point where maybe you can worry a little bit less about that overnight low that you either wake up for or you worry about overnight. So I'll note that where we started when we were thinking about you have to be on these devices. This is mostly a myth, but there are some good reasons to consider these different devices and different advancements. But ultimately, it really is this balance between your personality, your child's personality, kind of preference, quality of life, and the outcomes that you expect to receive. You may receive an improved outcome in certain areas, but is it worth the extra hassle? Those are the kind of decisions that you guys have to make as families. But I will note that if you're ever told that you don't have a right to a device, then that's just wrong. And you can advocate for yourself, you can push on these things. There are obviously barriers from an insurance and cost perspective, but the reality is that you shouldn't have to earn some of these different devices. You should have access to them. The best predictors of outcomes include things like access to care and support, nurturing, supportive family environment. We've hit on that a little bit already. Parental involvement, staying involved. So even if no matter what regimen, device you're thinking about, these are going to hold true and are going to be more predictive of outcomes than any of the particular devices you choose. And sustaining the system that works for your family. Those are kind of the critical areas that you're going to see improved quality of life and health outcomes from.
So related to this piece, we actually published some research in the late 90s looking at self-esteem and self-worth of youth with type 1 and their otherwise healthy peers. And what do you think we found? Not only did they have equal levels of self-esteem, but actually many of them had higher levels of self-esteem than their otherwise healthy peers. And the thinking around this, around quality of life and the psychosocial functioning of youth with diabetes is that, so think about this, they've been challenged with something that most of their peers look at them and say, I could never do that. And this is a source of developing resilience because, when they get their first B on a test or their first partner breaks up with them or whatever, they've been through diabetes. And so we see this as a source of actually building confidence and building self-esteem. So myth or fact, family conflict about diabetes only causes problems with the diabetes itself. It's obviously a myth, right? So what we know about conflict, we've done a number of studies. Our group has, and many other people, Barbara Anderson has done a bunch of work, is that family conflict has both a direct effect on metabolic control or glycemic control, as well as on the management of diabetes. So it's an important variable to start managing in terms of helping your child to better manage their diabetes, whether it's through their behavior or whether it's through their actual glycemic control. And you can imagine that this gets muddy when you start dealing with kids who are in different developmental levels, and there's just normal conflict that families are having. And so how much of this is diabetes related and how much of it is not? We have seen this one dynamic called miscarried helping, which I'll describe just really briefly. What it starts with is this problem, and that's diabetes, and parents are invested in being good helpers. And so data on social support and health, whether it's morbidity and mortality, is quite impressive. Social support is one of our strongest predictors of both morbidity and mortality across the board, all the way back to the Framingham studies. And so parents want to be good helpers, right? And they also have an investment in being a good helper, but also an investment in a positive outcome from their helping. And what do we know about sometimes when we try to help and just the natural course of diabetes? It doesn't get better, and sometimes potentially gets worse. And so as soon as that happens, then they start questioning whether the child is doing their part because I'm doing my part as a parent. And then it becomes a blame game and people are embroiled in conflict. So what starts out, I see this all the time in the patients that come to see me, is really good families, really good kids who just don't understand how they got there. Is the parents wanted to be really helpful, and now they're pointing fingers at each other and embroiled in a great deal of conflict. So we've also run a series of clinical trials looking at problem solving around both diabetes and non-diabetes related issues. And what we found is clearly families benefit and children benefit, not just in terms of their overall functioning, but in terms of their diabetes related functioning with a pretty basic problem solving approach. I mean, think about it. We go to school and we're taught all kinds of things. We don't really get taught problem solving. We just kind of figure it out along the way. And families have their own unique ways of problem solving. And then when you superimpose diabetes on top of that, there's a lot of emotional overlay that gets in the way of good problem solving. And so through these series of studies, we've been able to demonstrate that you can take a family who's embroiled in a great deal of conflict, child's health is deteriorating as a result, and just teaching them basic problem-solving skills. It's a more democratic approach to managing things, improves everything, improves their psychosocial functioning, improves their family functioning, improves their health. So not just our group has done this, but Korey's group, Lori LaFell, Richard Rubin. So the idea that problem solving involves a different way to communicate about things. The language that we typically use when we're trying to solve problems is pretty emotionally laden and oftentimes makes people reactive and defensive. And so we coach families in how to change the way they talk around diabetes-related issues or other issues. So we avoid kind of finger pointing. What we see a lot of times is that there's a thing in psychology called the fundamental attribution error. Has anybody heard of this? So what the fundamental attribution error is something you've all experienced and you've all been a part of. So if you drive on the highway, you've experienced this. When someone cuts you off, what do you think? They did it on purpose, they're a jerk, they're whatever, right? When you cut somebody off, what do you think? It's an accident. I'm sorry, I didn't see you. So the fundamental attribution error is you attribute character to people who are doing things that you don't like, and that's driving their behavior. And when you do it, it's situational, right? It doesn't say you're a jerk. You don't cut somebody off and say, yeah, I'm a jerk. Deal with it. Sorry, pal. So I think we see this a lot of times in families where both kids look at parents kind of in a certain box and don't think about the situations that drive them, and vice versa. The parents kind of say things like, well, they're irresponsible or they don't care. That's part of the fundamental attribution error. And then just usually coaching people in some general parenting strategies we found has been quite helpful in the outcomes of these studies. Oops.
Thanks. So one of our final myths or fact is about diabetes has nothing to do with emotional maturity. Come on, myth, right? Right. So one of the interesting things about this was, there are a number of studies on this, but I want to highlight one. So this was a study that was conducted in Belgium and published a few years ago. And what they did was they took 450 young adults, 18 to 29 years of age, and they had 300 in the study that didn't have type 1 diabetes, and they had 150 with type 1. And they matched them on enough girls on each side, or enough women on each side, and then also similar ages. And what they did was they went through a whole host of surveys and questions and interviews about kind of what they engage in on a daily basis. And they were looking at emotional maturity, adult-like behaviors, how mature they are in different ways. What do you think that they found? Who won? The kids with the young adults with type 1 or the other people? Yeah. So what they found was really interesting was that compared with the people without type 1 diabetes, so these other young adults without type 1 diabetes, more of the individuals with type 1 classified themselves as adult. So they were viewing themselves as adults and engaging in many of these adult-like behaviors. And when they did, it was related to improved glycemic control and other outcomes. So I think that what this tells us in many ways is a reflection of the hard work that you guys do as parents in modeling, in thinking about effective problem solving, in encouraging life with diabetes as being something that's not just diabetes, but it's embedded in a lot of different aspects of life. And that these kids do grow up to be very mature. If you have a 15-year-old at home now, you may not think that and may not believe it, but by 25, or maybe earlier, you're going to see some of these characteristics that you're going to be really proud of. And the data really reflect that part of this whole idea of managing it does have some benefit on emotional maturity. So just as a quick summary, and Michael can jump in and add anything here, hopefully we've talked about some of the different areas from a psychological perspective that can really have a big influence on both the daily management and how your family interacts about diabetes, but also on specific health outcomes. The data are pretty clear that when you consider the psychological side and consider the different balances of what's best for you and your family, what's going to give you a quality of life benefit, that you can really achieve some very good outcomes.
I would just add one thing is that your presence here suggests that you're way ahead of the curve in terms of the positive impact you're having on your children. So showing this level of interest, you should not underestimate, has a potential huge positive impact. And I got into diabetes differently than Korey, obviously, because I don't have diabetes, but my advisor in graduate school I was assigned to has type 1, and I never turned back, and partly I never turned back because I found the young people in this group and the families are just an incredible bunch of people, and I'm just daily impressed that you guys do what you do and do it so well. So it's pretty impressive.
Thanks.
Yeah, we'll note Steve.